Good afternoon. This is Dr. McDaniel at GYN Corner. I'm a board certified obstetrician gynecologist in Midtown Manhattan, New York City, and I'm bringing to you all things health related for women. Thank you for joining me at the corner today. And let's see, for the last few days I've been doing the presentations on ovarian cyst, so please refer to some of the previous presentations for more details on the background. But in general, I started speaking about ovarian cyst because a lot of people don't realize that there are different types of ovarian cyst. Some of them are normal, they're what we call functional or hormonal cysts, and the rest are not. Of the cysts that are not normal functional cysts, there are several types. They can originate from the skin of the ovary, which is the epithelial cell line. They can originate from the germ cell line, or they can originate from the background tissue, which is stromal, or from the reproductive portion, which we call Sex-Cord. So you can have epithelial, Sex-Cord Stromal, or germ cell ovarian cyst. And a cyst is a pocket of liquid or a pouch of fluid. So all of these are cystic because they're either completely filled with fluid. I can't talk today. Let me get it out. They're either completely filled with liquid or they're partially filled with liquid. So today I'm speaking about granulosa cell ovarian tumors, and we call them cystic ovarian granulosa cell tumors because a tumor is a solid tissue, so it's mostly solid, but it has kind of polka dotted. It's polka dotted with blebs of liquid, and those are usually blood-filled cystic pockets. So it's kind of like Swiss cheese. If you cut the cyst open in half, it looks almost Swiss cheese, where you just have the divots, little pockets of holes, and those holes are filled with either yellowish clear liquid or brownish clear, kind of brown tinged dirty liquid, or with blood. And then the blood sits there, it turns dark, so we call it chocolate cystic changes, because the blood looks like Hershey's chocolate. Yum. And let's see, now granulosa cell tumors are pretty rare. They occur around 2 to 3% of all ovarian neoplasms, and a neoplasm is an abnormal growth, be it a cyst or cystic fluid or a solid tumor. But the granulosa cell tumors, only 30% are truly benign. So in general, if someone has a granulosa cell tumor, we consider that what we call a low malignancy potential tumor or a borderline tumor. So we treat granulosa cell tumors as if they're cancerous, but 30% of the time they will not act cancerous, 70% of the time they will. And the unfortunate part with the granulosa cell tumors is that they can recur. Now, less than 5% of the time will they occur on both sides, but they can recur even 5 to 10, even 20 years after the initial treatment was performed. The granulosa cell tumors are similar to the other tumors in that it's very rare to have symptoms before they're pretty large. So most of the time, if they're picked up and they're small, which would be like less than an orange size cystic tumor, they're picked up incidentally. Someone happens to get an ultrasound, or they happen to get an exam, and the physician can feel that there's a fullness or a mass on that side of the body or the pelvis, or they're picked up because the patient's getting imaging studies for other things. I had a patient who had back pain. She had an MRI for the back pain, trying to see if there was herniated disc or something, and they picked up a mass on her ovary that ended up being granulosa cell tumor. And so if they're large, then they're usually not there really aren't complaints of pain with it, but it's usually complaints of discomfort or pressure with activities, exercise, or any sexual activity, just a heaviness and a pressure. So the usual imaging study is an ultrasound, because the ultrasound will be able to characterize the mass. So be able to see, we'll be able to see on the ultrasound if it's all liquid or if it's all solid. If it's all liquid, it's a cyst. If it's all solid, it's a tumor. We'll be able to see if it's pockmarked, like these granulosa cell tumors. They have that Swiss cheese appearance where they're filled with liquid or blood in those pockets. And then the age group for granulosa cell tumors is across the board. They can be found in babies. We call that juvenile granulosa cell tumor, or in older women, and that's adult. They can also, a small percentage of the time, 5% of the time or so, they are found in men, and that would be in the testes or testicular mass. The bulk of adults who have, even though it's a rare tumor, the bulk of them will be usually middle age, so around their 50s, late 40s to late 50s. And about, I wrote down the number for this one. I know it's a fairly small percentage, around, I think it's 30% or so. Of course, I can't see where I wrote it on the pad here. Around 30% of the time, they will produce hormones. For some reason, I can't find where I wrote that. And that's because the granulosa cell is associated with the eggs in the ovaries, or what we call the oocytes. So they surround the oocytes, and they can produce estrogen the bulk of the time. Oh, there it is. 40, okay, so it wasn't 30%, it was 40 to 60% of patients will hypersecrete, so they will have an overproduction of estrogen. So sometimes if a woman has this tumor, we will pick it up because she has abnormal symptoms. So she'll have overproduction of estrogen, and that can produce a lot of estrogen-related symptoms. So abnormal bleeding, abnormal pain, tenderness, or growth in the breast. Sometimes even a lot of premenstrual symptoms or menstrual headaches, menstrual migraines. So we'll pick it up because of the associated hormonal responses. A small percentage of women won't produce estrogen. They will produce testosterone. So it's what we call an androblastoma. And the testosterone will give them masculinizing symptoms. So they'll have hirsutism, or male pattern hair growth. They'll have male pattern balding. They'll have beard, mustache, chest hair. They'll have enlargement of the clitoris and deepening of their voice, virilization symptoms. So in those circumstances, we always draw bloods to evaluate it. So it's a hormone panel, pituitary, brain, thyroid, ovarian hormones, and then free and total testosterone, circulating testosterone levels. Once those are evaluated and we see there's a mass, especially if it has the characteristic features of the granulosa cell tumors, which is the Swiss cheese or pockmarked appearance, they're usually quite large upon evaluation, then the surgery is the only treatment for that. It's complete removal of the ovary, not just removing the cyst, but complete removal of the ovary, because we treat granulosa cell tumors as a cancer until proven otherwise. And then we have what we call tumor markers. So the tumor markers are always going to be the hormones that are directly associated with this tumor, and those are two hormones called inhibin A and inhibin B. If someone has the hormonal abnormal production, say estrogen, or sometimes they'll have hormone overproduction called AMH, or anti-Müllerian hormone. These are hormones produced by the ovaries, or if they have the virilization testosterone, then we will monitor those hormones too. But predominantly it's the inhibin A and B, and then the AMH, and then we see what else was abnormal at the time of diagnosis. The treatment, if the tumor is really just confined to the ovary, it's just going to be the complete removal of the ovary, and then evaluation to see if there is spread. So lymph node evaluation. If there's any suspicion of lymph node evaluation, then it will be treated as a cancer. So that's going to be radiation, chemotherapy, and then hormonal manipulation, depending on what hormones are abnormal. So I hope that's been helpful information on the cystic ovarian granulosa cell tumor. It's a relatively rare tumor. 2 to 4% of ovarian tumors are in this category, but it's still information that's useful to know. So thank you for joining me here at GYN Corner. Please hit the follow button if you'd like a heads up on the presentations and you enjoy the GYN Corner information I'm presenting. Please hit the like button and leave comments or suggestions for topics. We also have a YouTube channel that's called GYN Corner. You can check out the podcast. We're on 8 different platforms for the podcast. And as usual, I always forget the platforms. I have them written out also. I know it's Apple iTunes, Google Podcasts, Podcast Addict, Spotify, Anchor, and then there is Radio Public, Pocket Cast, and Overcast and Breaker. Please hit the follow button for YouTube and please leave suggestions on the YouTube channel. Let others know what you appreciate and what you enjoy about being a member of the GYN Corner. And I hope everyone has a great rest of their Thursday. It's TGI Almost F. Thanks for joining me, and until the next presentation, bye.